All right, let's do it.
Hi, Chris.
Hey, Chuck, how are you?
I'm fantastic. We're back at it.
We are, and it's been a lovely week in St. Louis. I know that we keep saying that on the air, and we probably wouldn't tell people if the weather was awful, but it's been really good. And I actually have found a new way to unwind at the end of the day.
I want to hear it. You
So I
mean you mean not cooking or
Well, no,
prepping?
this is after the cooking,
Okay.
because we did some incredible weeknight meals this week. But getting in the pool after the kids are in bed, like putting on some music, just getting in the pool and just kind of sitting there, because then I can't be doing anything else. And
Now,
even just like 20 minutes has been very therapeutic.
heated? Your pool is heated?
Pool is full for sure. It's heated because my wife won't get in even if the pool is a toasty like 87. If it's like below 80 outside, like she's like it's just too cold. I'm like that's why you got to get in the pool.
I'm with her, but kids have a remarkable ability to not be cold in water, so they don't
Yeah,
care. But we
no,
can.
they're impervious. But yeah, no, it's that's been really good. It's been a nice way. It's been a busy week, so
I'm a little embarrassed to say that I took advantage of the weather for the first time yesterday, and the reason I'm embarrassed is it's already the end of May. It's the first time I biked to work this year.
wow.
Um, but it was 60 when I rode in the morning, and it was a nice 80 or so on the way home. Sunny, beautiful day. The park was hopping, so it was awesome.
Now, Chuck, I'm so American that on the fly I cannot convert that to Celsius for our international listeners, but that's a very pleasant pleasant
Yeah,
range of temperatures. Not
no
too
idea.
hot, not too cold. It's kind of perfect. Yeah, I
Yeah,
have this thing where like just internally, if I know it's really nice outside, and if I don't get outside it for at least a little bit, I like guilt myself. I don't know, it's weird, but because it's growing up in Florida, and then moving to New York and then subsequently here, like I never had a true appreciation for seasons until, New York and now here. Because like New York in spring was glorious. August in New York was awful. St. Louis in the spring is glorious. August is pretty bad
it's
in
pretty
St. Louis
bad.
sometimes.
There,
Um,
there, for all the listeners who do bike to work, and maybe it's elective, maybe it's mandatory, there's nothing like it. On the right day, it gets you going in the morning and gives you energy, and then lets you, as you said, unwind at the end of the day. It's awesome. And I am gonna get back into the groove.
nice. Well, friend of the pod, Sam Mogateri over in DC, he posted some pictures of himself biking to work and his kiddo biking to school. I was like, that looks pretty cool. So.
That's awesome. Hey, do we have any new reviews out there?
We do have some new reviews and some interesting kind of anecdotes, but I did want to shout out Jack Graham, who did left us uh, a great review on iTunes. So the ideal balance of education and entertainment, their genuine passion for hand surgery and unique collegiality make this a must listen for any resident interested in the upper extremity. So that's a 5-star review. Thank you for leaving that. Actually, it was Jack Gregory. Excuse me. I don't know if that's an actual pseudonym or your real name, but thank you for leaving that review. And then we've got a couple of interesting emails. I had an email from a certified hand therapist in Iowa who was emailing me about a patient that she was referring, and her name is Michelle McMurray. And at the end of this email, she said, on an outside note, I'm a huge fan of the podcast. I will admit I have been listening since the beginning. So, wow, over 3 years. Thank you. And really appreciate what you're doing with this. I've listened to the podcast over many long runs and feel like I've learned a lot of insight and information from both of you as well as your guests. I hope it continues. So thank you,
Super
Michelle, for
nice.
that, and thank you, Jack. Really, it helps keep us going.
Yeah. I think before we have a good topic to discuss, maybe we should thank our sponsors to start.
Yes, The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/ the upper hand. Go see them. They do good stuff over at Practice Link.
Yeah, absolutely. I mean, for a lot of people, the job search thing probably starts a little too late. I'd encourage our listeners who are trainees probably to start looking earlier than you think, mainly to familiarize yourself with the process and the options. You don't want
Yeah,
to kind of freak yourself out by looking too early and being too serious, but it's just good to know what the process looks like.
I think that's great advice. And I would add that, if you happen to know where you want to be, when you're done with your training,
Like
and you can
geographically?
geographically, and which, there's pros and cons to that. But if you do know, and potentially if you even know the practice, it's a huge advantage in fellowship, because then you can tailor your fellowship to some degree based on the needs. Obviously, you want to keep your fellowship education broad based, but there are always choices and options to make, and that knowledge is helpful. So I think, it's not crazy to start thinking about this between your fourth and fifth years of residency, and then potentially reach out to praxis again if you know where you want to be. If you're flexible and open, then it's a very different search.
Right, absolutely. And then I guess for those of you that listen that are plastics trainees, push that back by a year.
Sorry.
But it doesn't. Yeah, you got to be inclusive, Chuck. Come
Oh
on.
my God. I know. I know. Yes. So you were about to embark on a quite a journey, and I've recently had two great trips. You want to tell us where you're headed? And this episode will drop after you're back, but I think it's the anticipation of the trip is pretty fun.
Yeah, it's gonna be great. So I'm going to the APFSSH trip. So it's the basically the Asian collaboration of hand societies there, which is going to be in Singapore there for their Congress this year. Super excited about that. I think that there's going to be some really interesting talks. I was just looking at the program, kind of circling the stuff that I wanted to go to. I'm going to share some thoughts on radial nerve reconstruction, which is going to be fun, and we're gonna have a small live event for the upper hand, which you may hopefully be able to join us for, Chuck,
Well,
remotely.
yeah, it's on my calendar for this for Central Time in the US for this Thursday night, 11:30 p.m. I'm going to hopefully be watching basketball, and before I go to bed, I will, have a chat with you from across the world, and we have a special guest, and I'm going to try to get that episode edited quickly and get that to drop outside of our usual sequence.
That's awesome. So hopefully it works out. If you're listening to if you listen to the next episode after this one and it's not a live interview from Singapore, then you know that technically it didn't work out. So
Yes.
yeah,
So I have to admit that the meeting was not really on my radar, but I've been traveling, and I'll give you a brief summary of my travels. And a lot of people that I interacted with were going to this meeting, and it's a little U.S. centric not to be aware of this meeting, and I hope to potentially participate in the future. So I was in Israel for a week for the joint Israeli U.S. Hand Society meeting, which was the first one since 1979. It was fantastic, both the educational content, the collegiality, which was really fun, and seeing Israel for the first time with its historical sites in Jerusalem and its modern sites in Tel Aviv and the Dead Sea. Really a great trip, but several or more than several people were talking about this upcoming meeting, and there was some podcast love, which was fun to be a part of in Tel Aviv.
that's great. That's such a fun opportunity, an incredible opportunity. I mean, culturally, I think it's probably once in a lifetime to get to do that. So, that's great you're able to do it. Yeah, I remember going to conference that morning and realizing that half of the hand service was in Israel. So
Yeah,
the
this
rest of us held it down.
it was Marty Boyer's idea, and David Brogan and myself joined along with, I don't know, maybe there was 12 or 15 other hand surgeons from the US. So really, really remarkable. And then I came back and worked for a week. Of course, had some flight issues, so it was late to clinic on Monday morning, but did make it. And then worked for a week, and then headed off to Minneapolis for the 2021 delayed COVID delayed World Congenital Symposium on Upper Extremity Malformations, which we renamed because malformations is, suggests bad formation. And apparently that can be bothersome or even offensive. And so we're renaming it. But that stuff aside, what a meeting. It was incredible. I was really proud of kind of what we had put together, and the speakers were remarkable. There were about 300 attendees
Wow.
from across the world. Majority were surgeons. We had a great therapist showing with a therapy pre-course organized by Amy Lake from Dallas. So this meeting, and Van Heest was the local host, and certainly the co-organizer with myself and Michelle James, and really, really great. And I learned a lot, had a lot of fun, A lot of people were headed over to Singapore right after this meeting, after that meeting. So it was really fun. I'm happy it's over, but happy we pulled it off.
By all accounts, both talking to people and then seeing things on social media, a resounding success. So big tip of the cap, as we say over here, to you and Michelle and Anne for pulling off an amazing meeting. Everybody was raving about it.
Thank you. Well, I must agree. I will say, Chris, that there was a little podcast love and a little podcast frustration from that crowd, that there wasn't more congenital discussion. And I tried to explain that, yes, some would be good, but I struggle with making sure we keep this podcast interesting to as many people as possible.
Well, I mean, I know that there has been some interest in congenital. So I got an email from a colleague I've yet to physically meet in person, from the Philippines, and he was telling me that he sent a selfie with you and him and said, "I told Chuck that we need more congenital." And I said, "You know what? If you want this podcast to continue to be a two-way street, we can't do too much congenital, or we can have somebody else on and I can fade to black, and that's okay with me."
Yeah, we'll figure out a way to squeeze some in. But we are going to sort of touch on my population. Let's talk a little bit about the impact of age and pathology and surgical decision making.
Yeah, no, I think that's a super interesting comment. I actually have an anecdote that made me think about that. I saw a patient in clinic at some point recently, I'll put it that way, who had at this point, a displaced scaphoid race fracture, but it had been missed for about a month. I had seen an outside hand surgeon, the old outside surgeon, and not to be named.
He or she is
Initial,
busy, that outside
exactly.
surgeon.
A small a small aside, and I may have told this already on the podcast many episodes ago, but when I was in residency, we talked before about how at my training we had to make a lot of PowerPoints for Pete's conference. And so I'm just sitting there just slogging through these PowerPoints, and the medical student is there helping me. And the medical student's like, "Where is this OSH? Where is this? They seem to send a lot of patients to you guys." So for those of you that aren't familiar, that is outside hospital. But
Yep.
anyway, so this outside surgeon, took X-rays. Initially, apparently the X-rays were negative, but the patient continued to have pain. So I found our way to our injury clinic, and then our injury clinic provider asked me to see the patient because at that point our X-ray showed that she had a displaced scaphoid fracture. Teenager, high school volleyball player, about to enter club volleyball. Um, the X-rays that we had showed some displacement, but it was kind of like, yeah, it might be okay. This kind of gets into the what are your preferences in terms of return to activities, age. So how would you kind of handle that situation with a teenager who's a volleyball player, say borderline displacement, versus somebody who, I don't know, say they're a strapping 39-year-old hand surgeon, or a 39-year-old who is not a hand surgeon. Uh, how would you handle that discussion?
It's funny, my one of my talks in Israel was on the adolescent scaphoid fracture, and
I heard that was an incredible talk that generated a ton of discussion.
it was surprisingly generated a ton of discussion. But I think the interesting factor is that what you don't want to do in certain conditions is give kids too much of the benefit of the doubt, meaning, oh, they're a kid, they'll be fine. And I think we do that. All of us do that. All of us are guilty of that. And so I just shared a brief protocol, which is not the point of the podcast, but basically, if there's suspicion in the emergency room or urgent care, hopefully they're immobilized, and I do it in a way that is not removable. They hopefully come back at 2 weeks for repeat X-ray and repeat exam. If X-ray is normal, exam is normal, move on, let them ramp up. If exam is painful, X-rays are normal, then you have a choice. You either put them in a cast or you get advanced imaging. But I think the mistake we sometimes make in kids is assuming that the X-ray is okay at 2 weeks, they're fine. But as your case, I presume that I got that about right. If your case is any indicator, that's not what happens, and there can be a fracture, and it displaces with activity. And if it's displaced on X-ray, it's displaced, and so you could get a CT scan. In fact, I probably would, unless you're just deciding to go to surgery. Of course, we know there's always a little resorption as the healing starts, so that can make displacement look a little worse. But for me, I would either go to the OR, or if there's any doubt about whether I had to, I'd get a CT scan.
Well, so interestingly enough, So first off, for your algorithm, is that for kind of radial sided wrist pain and snuff box tenderness in an adolescent?
Yes, thank you for clarifying.
Okay. And then when you say the exam over time, is that point tenderness over the snuff box?
Yeah, because I think as you and I both know, yes, if there's pain radially over the snuff box, that's concerning. And it has to be asymmetrical pain, right? Because it's just a little bit of a sore spot to push. But that pain goes away and scaphoid non-unions happen, and the pain may not be there at 6 weeks or 8 weeks or 10 weeks. And so you have to have a threshold to make sure you don't miss it.
Man, I had some good training because what you just described is exactly what I did. So I actually pushed on both snuff boxes. And for those of you, I don't know, do they still call it the anatomic snuff box in med school? I mean, because who's putting snuff in a snuff box now? I don't know. I mean, like, what are we in Plantation South
Yeah,
back in the
not
day?
sure. Good point.
But I pushed on both snuff boxes and said, does this feel different than the other side? And is it worse? And the answer is yes. And we had the discussion. And, in terms of age, because this patient really wanted to get back to volleyball, I mean, initially I kind of said, look, I think this is displaced, but I think the best way to really quantify that and really objectively look at it would be a CT scan. But again, if I gave you the option, like if you want to just go to surgery, we can go to surgery, because that would, I think, address your desire to get back to stuff sooner. And so the initial plan was then to hold off on the CT because it wasn't going to change my surgical decision making and proceed to surgery. Is that pretty much, if you were to decide like maybe we could treat this non-operatively, would you get the CT? And then if it was like, clearly displaced on the CT, would you recommend surgery at that point or push it a little bit? Not push it, but kind of steer the patient in that way?
Yes. So I think that, I get CT scans for two reasons. One, to plan surgery, like if I really just need to better understand morphology. For example, I had a 4-year-old malunion in a teenager. I needed to understand the morphologic changes in the scaphoid before I went to the OR. That was helpful. And then sometimes I'll get it to help with the surgical decision making. But let's be honest, if a fracture looks displaced on X-ray, it's only going to look more displaced on CT scan. So that could, increase your surgical indications. I doubt it's going to decrease it.
What are your indications? How much displacement is enough displacement where you're going to say you're going to recommend surgery? And does that threshold change? Does that threshold change with different ages? Because I remember in training, at least the pendulum was very much in the operative camp for scaphoids when I was a resident. And we would joke that there was millimeter to displacement that that was going to the OR, at least in the Upper East Side.
Well, I think a millimeter is my threshold, honestly. And I do think I probably have a little bit more tolerance in a kid than in an old person like me. But not much. It's not much different. Um,
But how
even
accurately can you tell a millimeter on an X-ray?
well, on an X-ray, no.
Is
I'm
that
I'm talking
okay?
on CT. Totally
On
fair.
CT. Okay.
But if it's displaced on X-ray, especially for the acute, the X-rays taken in the acute phase, if it's displaced on X-ray, it's displaced. Kind of
Yeah.
period, end of story for me. The question for me in the adolescent is, what do you do with the proximal pole? Like, let's say it's not super proximal, but kind of the proximal third, middle
Hmm.
third junction. Can you give those a chance to heal without going to surgery in an adolescent? And here's my personal story is that my nephew lives in Denver, and I asked him to see Lou Catalano. I thought for sure he had that fracture. I thought for sure Lou was going to recommend surgery. He said, no, let's give this a chance to heal non-operatively. My nephew's very active, but he was okay with that. And sure enough, 8 weeks later, by CT scan, it was healing. Probably took about 10 weeks to totally heal, but it healed. So you don't think we have to knee-jerk rush to the OR in proximal poles in the adolescent, and maybe we can be a little more conservative than with the adult, but I don't know. What do you
All right.
think?
So I agree. I mean, I think that the calculus and the conversation changes in terms of how you counsel patients based on middle third versus proximal third. Um, but I guess you have to feel it really is feeling out the patient and their time frame. I do tell people just anecdotally for scaphoids 10 to 12 weeks if treated non-operatively in the cast in terms of healing.
Mhm.
And earlier with surgery, but it's not like it's saving you tons of time. I mean, it's giving you a little more confidence that you probably can get back to stuff sooner if you've got a screw in addition to at least 50% bony healing, as we've talked about in prior episodes. Um, I guess for you, like let me put the question a different way because you keep dodging me. So 2 millimeters displaced 15-year-old high school athlete versus 2 millimeters displaced 35-year-old desk warrior versus 55-year-old
I'm not
executive.
55.
I'm not 35. So so yeah,
Um,
how would you treat 15, 35, 55?
all get surgery if with 2 millimeters of displacement. I think if it's like maybe a little less than a millimeter, then maybe the adolescent gets a trial if they want of non-operative care, uh, but the other two get surgery.
Okay. Very, very helpful to know because I think that, I would probably have a discussion with each of the groups. I probably would not for the 55-year-old executive. I would have a lower threshold to proceed with non-operative treatment with obviously casting, not a removable brace. Because I think that there's a chance that that patient probably doesn't need to get back to stuff sooner rather than later. And again, I don't want to be ageist, but you have to have a conversation about how quickly people want to get back. Because I fixed a distal radius in a 75-year-old person who really wanted to play pickleball. So
Pickleball is important. I guess that the thing is, cats are not fun to wear. And one of my biggest challenges in practice in general, not just with scaphoids, is the idea of treating someone non-surgically with the risk that they might then need surgery. And if you do that in a 15-year-old or maybe even a 55-year-old and say, okay, we're going to put you in a cast for 6 or 8 weeks and hopefully you heal. If you don't, we'll do surgery then. That's like, to me, that's terrible. Not terrible care because it just happens sometimes, but it's got to be terribly frustrating to hear that's a possibility as a patient.
Well, yeah, so I think that that's something that I did not appreciate until I came into practice. And I see that in our trainees, and this is nothing against them. I think it's just the lack of kind of real world experience. Because then they say, well, why are you treating this? Why are we even thinking about treating this non-operatively? All you lose is time. And I'm like, well, time actually is quite important because of the scenario you just described. If somebody is expecting to want to get back to stuff as soon as they can, and you give them this perhaps inflated sense that this is going to be okay without surgery, and then it displaces or it doesn't heal, and then they end up losing 2 to 4 weeks or 6 or 8 weeks, which is a valuable chunk of time in somebody's life. I mean, doing surgery in some ways sometimes allows people to start that recovery process earlier and allows them to move on.
Absolutely. Can we do another age-related case?
Yeah, why don't you toss another one out or
All
kind
right.
of steer that conversation? So
Let's take a 15-year-old right-hand dominant baseball player who comes in after being referred from an outside institution. Patient has medial elbow pain. He has numbness and tingling, which comes and goes in the ring and long finger. He has negative nerve studies, and he's here to see you. And he said the other doctor didn't think surgery made a lot of sense, given that the nerve studies were negative. But he's, having some trouble with baseball. He doesn't really have trouble with daily activities because the numbness really does come and go. And I can give you one more exam, Pearl, if you want, or you can tell me how you would approach this kid, and we'll get to the same endpoint.
uh, what position?
He plays outfield.
Okay. All right. And then I think that where you were leading me is the stability or lack of stability of the ulnar nerve.
Yeah, I would tell you two things. Number one, his UCL is intact, which I wasn't, you don't really worry, but it's our obligation to make sure it's okay. And then I think that's the most important point is examining the stability of the nerve. And sometimes that's obvious clinically. Sometimes someone like you with an additional skill set can use an ultrasound to understand. But in this adolescent population, I think it's usually pretty obvious if the nerve is symptomatic and unstable. And that was this kid's situation. So now you have this 15-year-old who has done no non-operative care, has an unstable and symptomatic nerve. What do you do?
Well, hold on. Before I want to take a little detour, which I can't believe I'm asking a sports related question, but in a non-pitcher, but an outfielder who has to throw, how important is the UCL?
I think, so the way I think about it, and there may be listeners who have more knowledge than I, the way obviously pitchers are pitchers and they need the UCL. Shortstop and third base really throw high velocity regularly. The positions that might be considered more guarded, certainly first base has a lot less throwing. Second base still throws a fair amount, and the outfielders throw irregularly, but are required to really put a lot of velocity on the ball. So outfield's a little safer and less demanding than the other positions, except for first base, but I think still demanding, and I think it could be a problem.
Catcher?
Catcher, I would put it in the same category as not quite pitcher, but probably a little more than shortstop and third base, just given the intermittent velocity needs.
Good. So my detour here is we've immediately lost all international listeners because nobody cares about baseball anymore. It's all
Well,
about
except for our Japanese colleagues, and even in
right.
Israel, it was interesting. There's some baseball in Israel, I learned.
I'm sure there is some, but we're not
Yes.
talking about the footy or anything. Can you tell me how you examine stability of the ulnar nerve? Because I thought I was doing it correctly for a while, and then I really went back and read the paper that described instability, and I changed how I examined because I wanted to follow what that paper described.
Well, this is super interesting, and obviously I'd love to hear your take. And the way we described in the paper we wrote, this is sort of pre-ultrasound when we did basically it's an interesting idea. We tried to look at asymptomatic um, pediatric and adolescent patients in a large number, and these were essentially siblings of
Is
patients.
this like the waiting room of the shrine?
Yeah,
Okay,
exactly.
nice.
Exactly. And so the way I do it still to this day, I kind of became more comfortable with it was, first of all, just I put my index and middle finger on the ulnar nerve and just gently move the elbow. That usually doesn't help too much. And then what I do is I flex the elbow passively, maximally, and I put my fingers on the posterior aspect of the medial epicondyle. And one of a couple of things that will exist. One, the nerves behind my fingers, i.e., sitting in the groove. Two, the nerves clearly in front of my fingers, which means subluxated. Or three, it's under my fingers, which means perched. And so you still may not know that, but then as you go to straighten the elbow, that nerve will want to fall back into the groove if it's anterior. And so to me, that gives me the most insight. Obviously, it varies based on body habitus, but it's pretty reliable, at least without the ultrasound. How do you clinically examine?
No, I think I love that. I love your description of it and kind of how you've broken that down for subluxation versus dislocation versus a stable situation. I tell our trainees that you know, with elbow and maximum flexion, you are trying to push that nerve out of the groove. Okay. And if you can't push it out of the groove, then that's obviously a stable nerve. If there's a little play and a little bit motion, you get into the situations you described. But as you ask the patient to extend the elbow, you're trying to keep that nerve subluxated or dislocated. And if you can keep the nerve pinned anterior, then that's obviously a dislocated and quite unstable nerve. If it kind of has some play and it's moving back and forth a little bit and trying to get back in the groove, that is your perching or subluxated situation. But I don't think that's talked about enough, how to properly examine for stability of the ulnar nerve when you don't have an ultrasound, et cetera. So that's why I took a little second detour on this. Not dodging your case, though, I promise.
Well, I want to kind of present two, scenarios with this. So the first is the scenario that I presented: unstable nerve, electrodiagnostically negative, intermittent symptoms. Do you offer this patient non-operative care? If so, what does it look like? And if you do or don't, and you consider surgery, what do the surgical options look like?
I think you offer them non-operative care, but they've probably already tried it or they're not going to be into it. So if night splinting is something that is going to help quiet a nerve, but it's not going to change how the nerve behaves during the activities that they want to participate in. So, if you tell them to modify their activities, then and they're going to do it and take rest from throwing, then great. But if this is something that they're going to continue to want to do and you can give them something to help them do that and they have the time to recover from the surgery, then I think it's very reasonable to offer them surgery. How do you approach it?
Well, I have two questions, which really makes me smile because when I was at one of these meetings, someone came up to me and goes, "Chuck, I have two questions for you," and I didn't immediately know they were
Two
mocking
things.
me. Two things. So my first question is, when you examine the other side, do you typically find an unstable nerve? If the symptomatic side is unstable, do you agree that the contralateral side is also typically unstable?
I honestly, I don't often examine the other side unless they're having symptoms. But I know that the paper you guys wrote showed that there's a subset of patients who have bilateral instability, and that's kind of how they're built. Bob Hotchkiss used to say that the ulnar nerve is a design flaw from the creator or God or whatever your beliefs are. Um, but because that just a third of the population tends to have at least instability on one side. So I don't always examine the other side.
Yeah, my experience, well, that's fair enough, but my experience is yes, they are generally unstable on the other side also, but asymptomatic. And then you have the
Hmm.
discussion with the family. Once a nerve becomes symptomatic, unless you modify your activities, you won't give it a chance to calm down. My other question is any role for therapy, nerve glides? I never know when to ask for that. Um, it seems to me sometimes if there's multiple levels involved in the cervical spine, sometimes nerve glides make sense. Would nerve glides be appropriate or therapy be appropriate in this patient?
I don't think nerve glides would help. I think it's probably looking more at mechanics and the potential involvement of something like TOS if you've got some overlay of TOS on top of the irritable, unstable ulnar nerve with throwing. If there are some things that could be improved mechanic wise with throwing, then perhaps there's a way to address this without surgery. But if it really is localizing to the unstable ulnar nerve at the elbow being irritated with throwing motion, and there isn't a whole lot else going on, I don't think therapy is it would be very helpful. Although I would welcome any of our therapy colleagues who are listening to please let us know if you've got some tricks in your bag, because that would obviously help us. Because if we can avoid surgery, it'd be great.
I think you asked me a question before I went off on a tangent, but I don't remember what it was. But surgery, what are you offering?
Yeah, I mean, you can talk more about this than I, because I mean, you wrote the paper, in terms of, doing decompressions versus transpositions in this particular population. It was a retrospective study and, methodologically had some, shortcomings, but, I think it was a very helpful paper in terms of understanding, that patients who only have in situ decompressions in this age group with this, athletic demand don't do predictably well.
I think that's well said.
Is
I
is
don't,
that a fair assessment of your paper?
that's a fair assessment. So, this patient's unstable. So we're going to transpose this
Right.
patient. But no, I like your point because I was going to raise the same point. So we're going to transpose this patient. For me, I really, really, really want to do a subcutaneous transposition, not a submuscular in this patient. Fortunately, almost all adolescents do great with that option. Um, so that to me is a good, reliable result. I've gotten really much more aggressive in their rehab. I soft dressing after surgery, sling for a couple of weeks, get their motion back. And then at 5 or 6 weeks, they are almost all doing well. And I rapidly progress them so that by 7 or 8 weeks, they're back in their sport, which feels aggressive to me. Maybe listeners are like, oh, I do that all the time. But for initially, I was 10 or 12 weeks before I let them get back to really throwing activity. So been happy with an aggressive post-op protocol.
Do you, I know that you've adopted kind of that adipofascial kind of broad uh, barrier for the nerve and keeping it to the front. Do you do that also for this population, or do you do a kind of the fascial sling that is more classically described? And does your rehab change based on which type of transposition you do subcutaneously?
I still like that adipofascial flap, so to speak, when at all possible. Occasionally, I'll have a really thin adolescent, especially like a volleyball player. Then you really worry, is that repetitive trauma, is subcutaneous the right move? I still think it is the right move, but if they don't have good subcutaneous tissue, then the Eaton fascial sling might make sense. But I just like it less and less, and I like this adipofascial flap more and more.
Does the rehab vary based on, because you're kind of sewing fat to subQ in some points for that adipofascial. So does that, do you find that to be less sturdy or?
I think the adipofascial is better. I think it heals more rapidly, and I think it just I feel more comfortable with it. But fundamentally, I don't think the rehab changes. And then getting back to your question, I no longer do decompressions in the adolescent population. So if this patient were symptomatic but stable, I would still transpose them. I just think there's something about this age group that makes me far less confident of a successful outcome with decompression. And we know that with decompression, in the older patients, it can work really well. But we know if we have to revise a decompression from Ryan Calfe's work, then the results are going to be less optimal.
Right. So when's the inflection point on age when an adolescent gets into what age, then they become more of a candidate for a decompression alone if they have a stable nerve on exam and on ultrasound?
Yeah, it's interesting. I don't know what your sense is. There definitely is I don't know if it's bimodal age distribution, but in my population, I see this in adolescence with, seriously, sports related. Then I tend to start seeing it in the 35 plus aged population. I don't know that I see a lot of 20 to 30-year-olds or 20 to 35-year-olds with this. Of course, we see some, but I would say in that adolescent population, it's just one treatment. And then I consider decompression in older patients. And as we've talked about, my use of the decompression option has declined over time. I don't do it very
Right.
often. It has to be the perfect patient. Do you agree
So
with
kind of
that
yeah, I agree with that. I mean, as you get into the mid 30s, that's when you start to think more about decompression alone. And then
as an
does that
option?
change, does that shift back towards transpositions in, say, 55, 65, 70-year-old patients?
Yeah, with more definitive considerations and possible submuscular as well.
Okay, and is that based on the status of the ulnar nerve in terms of, is it if there's advanced clinical findings in terms of, atrophy or weakness or anything like that? Like, say you have a healthy nerve still on a nerve study and it's stable in a, 55-year-old.
Decompress.
Go ahead.
What about you?
Yeah, same thing. I mean, I
Okay.
actually don't think this, aside from the caveat of the adolescent kind of athlete, I don't think the decision making for me changes a whole lot based on age. So it's not like the scaphoids.
Oh, interesting. I think we probably could have a part two of this sometime about some age-related decision making, but I like this. We got a little sports, we got a little nerve.
Yeah,
Hopefully we
yeah,
satisfied some of our listeners.
you can continue your ageist trend. So,
Yeah. All right. Well, you're on call this weekend, so go get them.
oh yes, so excited. Good people of St. Louis. Have a wonderful weekend.
You two have a great trip.
Thanks.
All right, bye.